guys for the opportunity to present this CareCell model, which in a sense, I guess, wraps together what the previous speakers have said in a way to address an additional 2.5 million people requiring art. The 1990-90 strategy implies that as many as 30 million people are going to have to be tested to find another 2.5 million on a test and treat basis. And I believe this really means that we're going to have to go beyond just tweaking the treatment capacity in present facilities, because it's got to go up between 500 and 100% depending on which facility, and certainly double at the national level. And I think this really means that we need to go beyond just tweaking efficiency and finding new capacity to treat antiretroviral, to roll out the antiretroviral care to patients. So we propose this new model, which we call the CareCell approach, which in a sense is wrapping up the GP-centered approach. And it's derived essentially from Aurum's experience using the GP model in the private sector. In essence, as you can see over there, it's a small network of geographically related HIV care facilities, which could include the GP at the center, a number of NEMART practitioners in the private sector around that, which could also include screening sites, treatment support sites, and even local pharmacies, all linked together in a managed care model, typical managed care model that you might find in a medical scheme, or as has been rolled out by Right to Care as well. In our hands, we applied this managed care model. It's very algorithmic and uses a lot of guidelines to work it out, and it applies art across the board. And in our hands, and from some painful lessons learned as well, we found that a fee-for-service approach works much better than a capitation approach, but we can discuss that later. I know this is old data that you can see here, but 2008 is when we ran this program, and that's a world away in HIV terms, and bearing in mind that the patients then had a low starting CD4 count and a very tough regimen of drugs with tough outcomes and side effects. We had reasonable, I believe, outcomes. The viral load, as you can see there, was 82% suppressed at 12 and 36 months, and retention at 60 months was pretty good, given the time that we were dealing with at this point. I believe that by combining the experiences of other partners, such as you've heard a little earlier, we can achieve much more. So the model then, to take it further, the bigger picture would be to combine a whole set of these networks in a super network linked across the country. And you can see in the middle there a network information system, which is any one of the major managed care systems or even in-house ones, where data flow is really critical to ensuring that patients are managed and link up to the NHLS lab system and indeed to a pharmacy supply chain. In our particular setting, we used a courier pharmacy model similar to Right to Care, and it worked extremely well. So we built a model around this, and assuming that if you want to treat all 2.5 million patients and all of them require treatment, on the assumption then an uncomplicated case needs to visit twice a year, and perhaps a complex one 4 times a year, you can see from that column over there that around 1,000 CareCells would be able to manage this patient load with only around 20 patients a day being seen by the entire cell. This doesn't mean that all the patients have to go and see the GP themselves. We have drug delivery models proposed elsewhere that can easily support this. So what are the potential roles then of the general practitioner and the CareCell overall? The general practitioner, we believe, should be the custodian of clinical governance and can manage the complex patients. And obviously from the practice then would come the central administration of patient data flows, which we found would be absolutely essential to managing that algorithm. The CareCell itself includes screening and the diagnostics, initiation of ART, and the whole gamut actually of ART provision, but could go beyond that. It could go beyond into MMC, as Dirk has already alluded to, and even managing other areas such as tuberculosis, diabetes, hypertension in the NHI model. They could also even provide a node for training and a node for resistance sentinel sites. So what are the critical factors? We believe that you need to carefully choose your practitioners. Not all general practitioners are created equal. And you need to make sure that the practitioners that you choose have a care for HIV. Obviously, they have to be up to date in their training. Ours were somewhat behind if you go to today's treatment. You need that rock-solid information system. You have to superimpose a managed care system, and you have to have data management, decision-making in order to prevent abuse and to make sure that we have proper clinical and administrative government. I acknowledge that we still need to do costing exercises around this, but our costing in our hands was similar to what Right to Care experienced. So finally, given the scale of the treatment challenge that we face ourselves, the CareCell model, I believe, represents an opportunity to leapfrog marginal capacity increases and address the second and the third 90s of the overall strategy. I'd like to acknowledge my colleagues at Aurum and FPD and the National Treatment Think Tank, as well as over 75 general practitioners who contributed to this. Thanks so much.
Thanks, Dave. I'm sorry my boss is not here because he would have loved the word leapfrog.